Welcome back to the deep dive. Today, we're tackling something that, honestly, if you get this right, it really levels up your coding game.
It really does.
We're diving into those CPT codes marked as separate procedures. Mastering this can give you a serious edge both on exams and, day to day.
Absolutely. It's this little label right there in the code descriptor, often in parentheses, but it trips up so many people.
It does.
So our mission today is pretty clear. Unpack this. Figure out when you report these codes, and maybe even more importantly, when you definitely don't.
Yeah, and the neat thing is, like you said, the clue is right there in the codebook language. You see separate procedure, often tucked away in parentheses, and bam, that's your signal. Your thinking has to shift right. It's not just what was done.
Exactly. It becomes, how does this procedure relate to anything else that might have happened?
Right. So let's define that relationship. What does CPT actually mean by separate procedure?
Okay, so when a code gets that label, it's telling you that the service described may be a small incision, a bit of exploration, a tiny excision, is usually considered integral.
Integral.
Or, a necessary part of some other bigger procedure.
Ah, okay. So it's typically part of something else.
Yeah, often it's historical. Maybe years ago, that code was for doing just that one thing all by itself.
Makes sense.
But now, maybe that step is just routine, something you have to do to perform a much larger operation.
Right.
So they needed a way to signal, hey, don't double dip here, don't build this separately if it's part of the main event.
Gotcha. That context helps a lot. So the immediate takeaway is financial and administrative, really.
Totally.
Because it's usually wrapped up in the main procedure. You just don't report it separately if it's done at the same time with that bigger service.
Assuming they're related, clinically speaking.
Exactly right. Assuming that clinical relationship exists.
Let's make that concrete. Like, say, a code for excising a small lesion says separate procedure.
If the surgeon nips that out right before doing a big, complex reconstruction in the exact same spot...
Then that little excision, it gets bundled, swallowed up, like you said.
Okay.
It's considered part of the approach or the necessary prep for the main reconstruction. You only code the big one.
Right. It's built in. Which leads us nicely to rule number 1, I guess. The bundling? When do we report it?
Exactly. This is key. You don't report it if that separate procedure service is truly incidental.
Incidental.
Or integral to the main primary service performed.
And what makes it incidental or integral? This feels like where coders might get a bit tangled up. They see 2 codes. They want to report 2 codes.
Yeah, it's tempting. But you have to be really precise. For it to be bundled, 3 things usually need to be true all at once.
Okay, what are they?
1, it happens during the same operation, same session.
All right, same session.
2, it's done in the same general anatomical area.
Same place, okay.
And 3, and this is often the kicker, it uses the same surgical approach, like same incision or entry point as the main procedure.
Ah, okay. So if the surgeon kind of has to, I don't know, move some tissue aside or do a little preliminary step through the same hole just to get to the main target.
That's it, that preliminary step. Usually not separately reportable. It's just standard surgical technique for that primary procedure.
Got it.
Think about lysis of adhesions. That often has a separate procedure tag.
Right.
So imagine a surgeon has to cut through a bunch of scar tissue that's the lysis right before doing a major bowel resection.
Okay.
If removing those adhesions was necessary just to get to the bowel and do the resection properly, then the lysis is integral. It's same session, same area, same approach, and clinically necessary for the main event. The lysis code. Gone. Bundled into the resection.
Okay, wait. Let me push back slightly here because this is where, the money comes in. What if that lysis was super tough, took an extra hour? Maybe the lysis code even has, higher RVUs than the main bowel resection itself. Do we still bundle it?
That's a really sharp question, and yeah, it comes up.
Yeah.
But the answer, pretty consistently, is yes, you still bundle.
Even if it's worth more?
Even if it technically has higher RVUs or it took way longer, the rule is driven by the clinical relationship and necessity, not the dollar value or the work units. If the lysis was needed to perform the resection, it's integral, period. Non-reportable separately. The effort, the difficulty that's supposed to be factored into the value of the primary procedure. Clinical relationship trumps RVUs here.
Okay. That's a critical point. Clinical necessity first.
Always.
Yeah.
Now, moving on from bundling. Now, this is where it gets interesting. Rule number 2, the exceptions. When can you actually report that separate procedure code?
The exceptions.
Yeah.
Always important.
There are basically 2 main scenarios, and both hinge on proving that the service was genuinely distinct from anything else done.
Okay, lay them out for us.
Exception A is the easy one. Super straightforward.
Love easy ones.
If the separate procedure is the only thing done during that entire patient encounter, full stop.
So patient comes in just for that lesion excision,
Yeah.
nothing else happens.
Exactly. It stands alone, you report it, no modifier needed, no fuss.
Simple enough. What's exception B?
Exception B tests your understanding of, anatomy and clinical relatedness. You can report the separate procedure, even with another procedure, if it's totally unrelated to the primary procedure.
Unrelated. Okay.
And it's performed on a different anatomical site or maybe even a different organ system during that same session.
So distance matters. Location, location.
Pretty much. It proves the distinctness. Let's use that great example we looked at earlier. Surgeon does two things in one go.
Okay.
Main job, an appendectomy, down in the abdomen.
Right.
Secondary thing, excising a benign skin lesion, but it's on the patient's arm. And let's say that skin lesion code says separate procedure.
Okay. Happy in the belly, lesion on the arm. Definitely different spots.
Exactly. The arm lesion removal is completely unrelated to the appendix removal. Different body part, different surgical field. That satisfies the distinctness requirement.
So the arm lesion excision can be reported in this case?
Yes, it can. But, and this is crucial, it leads us straight into the coder's toolkit. Modifiers.
Modifiers, of course.
When you're reporting under Exception B, this unrelated different site scenario, you absolutely must use a modifier. You have to signal to the payer why you're reporting it separately to stop it getting automatically bundled.
Makes sense. Which modifier are we talking about?
You need modifier -59. That's the classic one, distinct procedural service, or often preferably now, one of the more specific X modifiers.
Okay, -59 or an X mod. You can't just list the code alone.
Nope. You need to append that modifier to the separate procedure code to justify it.
You mentioned the X modifiers. Refresh us quickly why the shift from just using -59. What's the deal with those?
Good question. Modifier -59 got a bit of a reputation for being, well, a catch-all. It could mean several different things, different session, different site, different procedure, different encounter. Bit ambiguous.
Right, payers probably didn't love that ambiguity.
Exactly. So Medicare and others introduced the X modifiers, XS, XE, XU, XP, to force more specificity.
Okay.
So in our example, instead of just -59 on the arm lesion, you might use XS.
XS meaning?
Meaning separate structure. You're explicitly telling the payer, this is distinct because it was performed on a completely separate anatomical structure, the skin of the arm, which has nothing to do with the appendix surgery.
Much clearer. Less wiggle room for denial.
Precisely. It strengthens your claim significantly against those automated bundling edits.
Okay, this is gold. I'll pause and maybe crystallize this decision process because you need a quick mental checklist when you see separate procedure. Okay?
Definitely. We need a filter. Let's call it the MJ GEM filter.
I like it, the MJ GEM filter. Okay, walk us through it.
All right. See, separate procedure next to a code. Apply these three questions in order.
That's question one.
Question one. Was this procedure integral, incidental, or just clinically related to another main procedure done in the same session? Think like that lysis of adhesions needed for the bowel resection.
Right.
If the answer is yes, it was related or integral. You stop right there. Do not code it separately. Bundle it.
Got it. Stop at step one if it's related. What if it's not related?
Then you move to question two. Is this the only procedure performed during the entire encounter? Like that standalone lesion excision we mentioned? If yes, it's the only thing done, you code it.
Right.
Simple. No modifier needed usually.
Okay. Only procedure code it. What if it wasn't the only procedure and it wasn't related?
Perfect lead into question three. Was this procedure unrelated to the other procedure? And D, performed at a distinctly different site or on a separate structure, like our arm lesion and appendectomy? If the answer here is yes, S, unrelated and different location structure, then you do code it, B-U-T.
You absolutely must add modifier -59 or, better yet, a specific X modifier like XS.
You got it. That's the filter.
Brilliant. Let's run the appendectomy arm lesion case through the MJ GEM filter one more time just to lock it in.
Let's do it. Primary procedure, appendectomy. Secondary, arm lesion excision, marked separate procedure.
Okay.
Question one. Is the arm lesion related to the appy? No. Different body systems, different locations.
Nope. Move on.
Question two. Was the arm lesion the only thing done? No, appendectomy was also done.
Okay, move on.
Question three. Was the arm lesion unrelated and on a different site structure? Yes. Arm versus abdomen, totally separate.
Bingo.
Therefore, we report the arm lesion excision code and we append modifier XS, separate structure, to prove its distinctness.
Perfect. That filter really clarifies the logic. It moves you past just, knowing the definition to actually applying it strategically, bundled versus distinct and billable.
And that strategy brings us to the final, really crucial takeaway: the documentation and the risk.
Ah, yeah, documentation. Always comes back to that, doesn't it?
Always.
Yeah.
When you use mid-of-9 or an X modifier, you're essentially putting up a flag for the payer that says, hey, I know this could look bundled, but trust me, the clinical facts show it's separate and payable.
So you're making a specific claim that needs backup.
Exactly. Your coding justification lives or dies by what's in that op note or the encounter documentation. The physician have to provide enough detail to clearly show the services were distinct. Separate structures, unrelated conditions, different surgical fields, whatever justifies that modifier.
Right. Without that clear documentation, the modifier won't hold up under scrutiny.
Precisely. Which leads to a final thought, kind of a challenge for you, the listener, as you dig deeper into this.
Okay, let's hear it. Since successfully getting paid for that separate procedure often hinges on proving that lack of relationship, that distinctness, what specific things, what measurable details absolutely need to be in the medical record to legally and clinically define one service as totally separate from another?
That's a great question. How does a surgeon document, say, a lysis of adhesions in a way that proves it wasn't just integral prep work for the main procedure, but something truly distinct and unrelated, perhaps in a different scenario?
Yeah. Thinking about that level of documentation detail, that's where you really start mastering the nuances beyond just the basic rules.
That's a perfect place to leave it. Definitely something to chew on. Understanding separate procedure isn't just about the definition. It's about the application, the modifiers, and the proof in the documentation.
Get this right, and you're well on your way. It's fundamental.
Thanks for diving deep with us today. We'll catch you next time.